Okay, let us continue from question number 4. A 33-year-old man comes to the emergency department due to fever, chills, cough, and shortness of breath. Over the last week, he smokes a pack of cigarettes a day, consumes 2 or 3 alcoholic beverages daily, and uses IV heroin 2 or 3 times per week. He is febrile and tachycardic. Blood cultures grow Staphylococcus aureus. Chest X-ray shows bilateral nodular lesions with areas of cavitation. The valve most likely affected in this patient can be best evaluated by auscultation at which of the following sites? A, that is on the right side in the second intercostal space. B, on the left side in the second intercostal space near the sternum. Then C in the fifth intercostal space near the sternum. Then D at the mid-clavicular line at, in the fifth intercostal space. For each A, B, C, and D region, uh, they have given option A, B, C, and D respectively. Pause it and give the answer. So the correct answer over here is option C. Okay, why option C? Option C, which is located in the fifth intercostal space near the sternum. This is the region for tricuspid stenosis and tricuspid regurgitation and VSD. Now, one thing which you should note is for these AV walls, right? Whenever there is stenosis, right, then the stenosis will produce diastolic murmur. In case of AV valves, the stenosis will produce diastolic murmur. Uh, like we have two types of uh, AV valves. One is tricuspid and one is mitral valve or bicuspid valve. The tricuspid valve, which are located on the let me draw it for you guys. Right, let's say if this is the heart, uh, between right atria and right ventricle, we have tricuspid valve, right? And between um, left atria and left ventricle, we have uh, mitral valve or bicuspid valve. For these, whenever there is stenosis, they will produce a diastolic murmur. But whenever uh, there is regurgitation, that is the fluid is moving in the backward direction, right? Just like that. That will produce systolic murmur, right? But this is opposite in the case of mitral valve. In semilunar valve, which are located it here at the outflow. Uh, the aortic valve over here, and over here uh, we have the pulmonic valve. What will be the sound over there at the aortic valve? Whenever there is stenosis, right, that will produce systolic murmur, right? It both semilunar valve, either if we are talking about this pulmonic valve, or either we are talking about the aortic valve, right? Both will produce, let's say if there is aortic stenosis and with that there is pulmonic stenosis, that will produce systolic murmur. What that will produce? Systolic murmur. But if there is regurgitation in mitral wall, in pulmonic wall, and with that in aortic wall, that will produce diastolic murmur, right? Now this is the opposite of the AV wall, that is atrioventricular wall, right? You shouldn't forgot this thing. Okay. Okay, good. uh, So um, in this case, we have tricuspid stenosis. We talked about this. Here will be a diastolic murmur, and if there is regurgitation, right, the best uh, its sound can be best heard at the same place at C location. And for VSD also, the systolic murmur is heard best at the point C. Right. Why not option A? Option A, you have to remember in this way that uh, let's say on the left side we have aorta. There will be crossing over. Right. So that will move. Their sound will be best heard in the place of uh, uh, second space on the right side. And on the left side, let's say we have pulmonic valve that will be crossed over here, right? So at location B, its sound is best heard, right? Remember this thing. So in option A, we can best heard aortic regurgitation, which is from root dilation. And is I talked about that. Whenever there is aortic or pulmonic regurgitation, that will produce diastolic murmur. So in that case, we will best heard diastolic murmur. And with that, we can also hear aortic stenosis sound. That is that will produce systolic murmur, right? But in this case, is they have presented the case of Steph Arias, right? Steph Arias, and with that, they have given the case of IV heroin, right? Steph Arias, and with that, IV heroin, uh, that will cause um, tricuspid stenosis, right? Because um Steph Arias in IV drug abusers, what it will cause uh, is infective endocarditis, and those whenever it causes infective endocarditis, that would lead to septic emboli, right? And those emboli. Let's say if we have over heart over here, right? Uh, okay. If let's say here septic emboli are formed, they will move forward, right? That will go to the lungs, due to which these uh, uh, due to which these emboli will form uh, bilateral nodular lesion and with cavitation in the lungs, right? So that's why the option C is correct. Okay. In option B, here, as I said, we will do crossing. Pulmonic stenosis and ESD sound can be best heard, right? But that is not associated Steph Arias, right? And one more thing is, though uh, Steph Arias in IV drug abuser can cause pulmonic stenosis, but that is not that much common, right? So that's why I have written it. Infective endocarditis affecting the pulmonic wall can occur in IV drug users and lead to septic pulmonary emboli, but it is far less common than tricuspid valve endocarditis, right? Then why not option D? Option D, that is on the left side, right? And the if there is uh, mitral stenosis, right, that will produce diastolic murmur, and if there is mitral regurgitation, uh, and with that, if we have mitral wall prolapse, that will produce systolic murmur, right? That can be best heard at that region, which is considered as the apex of the heart, right? But that is not associated with staph aureus and IV drug abusers. So they want to tell us this about this concept that staph aureus is causing uh, infective endocarditis that is most commonly affecting the tricuspid wall, which is located between uh, right atria and right ventricle. Okay, so option C is the correct one. Let me repeat these location. Aortic area, that is the second intercostal space. If we have aortic regurgitation from root dilation, that will produce diastolic murmur. And if we have aortic stenosis, that will produce systolic murmur. Then uh, on the same location in the second intercostal space, but on the left side near the sternum, we have pulmonic area. So over here, if there is pulmonic stenosis, that will produce systolic murmur, right? And systolic murmur is also associated with um, ASD in this place, right? So then this one they have not mentioned in the option. uh, in the same region, but below the second intercostal space, that is in the third intercostal space, below that second intercostal space region, um, we can best heard we can best hear the sounds of pulmonic regurgitation. You know, the first that was uh, the first in the second intercostal space on the right side, whenever there was uh, aortic regurgitation, that was from root dilation, and the sound which was best heard was of diastolic murmur. But over here in the third intercostal space, it is also aortic regurgitation, but it is uh, of valvular type, right? So that will produce diastolic murmur, but this is of valvular type, right? So the aortic regurgitation of valvular type, that will produce diastolic murmur in the third intercostal space on the left side, but the aortic regurgitation from the root dilation, that will produce the same diastolic murmur, but that will be produced will be best heard it in the second intercostal space on the right side of the sternum. So this is the difference. You shouldn't miss that. Okay. Then we can also best hear in this place uh, the systolic murmur, which is associated with hypertrophic uh, cardiomyopathy. Okay. Then in the fifth intercostal space, uh, which is considered as the which is near to the sternum, which is considered as the tricuspid area. Here we can hear uh, the diastolic murmur sound, which is associated with tricuspid stenosis, and the we can also hear the systolic murmur sound, which is associated with tricuspid regurgitation and VSD. Then, in the same fifth intercostal space, but at the apex level, in the midclavicular line, that is considered as the mitral area, that is the apex of the heart, right? We can hear diastolic murmur from mitral stenosis, right? And systolic murmur from mitral regurgitation and mitral wall prolapse. Now, let me give you one important hint that the congenital diseases which we have, uh, like ASD, that is in the second intercostal space, then VSD, which is in the fifth intercostal space in the tricuspid area. Then mitral valve prolapse, remember this, uh, which is also in the fifth intercostal space, but uh, in the midclavicular region, right? They all are producing uh, systolic murmur, right? Keep this in mind. Okay, so let's have a quick review. Cavitary pulmonary nodules, they are consistent with septic emboli, common complication of right-sided infective endocarditis, tricuspid wall in IV drug users, bacterial adherence that will damage the tricuspid wall endothelium. Staph aureus is the most common organism responsible for IV and infective endocarditis in IV drug users. A regurgitation of blood due to impaired closure of the affected wall that will produce okay uh, early or hollow systolic murmur of tricuspid regurgitation. As I mentioned, with AV wall, if there is regurgitation, that will produce systolic murmur. With uh, semilunar wall, if there is regurgitation, that will produce diastolic murmur. Keep this in mind. So this can be best heard at the fourth or fifth intercostal space at the left lower sternal border. Increases in intensity with maneuvers, increases right ventricular blood volume. Okay, uh, like inspiration, supine, leg raise. Okay, why not option A and D? Most aortic wall murmurs best auscultated in the second intercostal space, right upper sternal border. Mitral wall murmurs best auscultated at the cardiac apex near the midclavicular line, left fifth intercostal space. Infective endocarditis affecting left-sided heart walls uh, may cause septic embolization to the kidneys, brain, or other systemic organs, but not to the pulmonary circulation. This thing is important. Left-sided heart wall, if they are involved, those septic emboli will move to the systemic system, to the systemic organs, right? Like kidneys, brain, or other systemic organ. But here in this case, which is associated with right side infective endocarditis, that will produce emboli that will go to the lungs. This is the big difference, right? So why not option B? Pulmonic wall murmurs, second intercostal space, left upper sternal border. This thing is important. Infective endocarditis affecting the pulmonic wall can occur in IV drug users and lead to septic pulmonary emboli, but it is far less common than tricuspid wall endocarditis. Infective endocarditis in IV drug users commonly affects the tricuspid wall, septic pulmonary emboli, early or hollow systolic murmur of tricuspid regurgitation, best auscultated in the fourth or fifth intercostal space at the left lower sternal border. Okay. Now, uh, in question number 5, a 35-year-old woman comes to the office for preconception medical evaluation. She feels well, reports no health issues, and has had regular menstruations. The patient has been in elite long distance swimmer since high school and recently retired from professional competition. She still continues to practice swimming regularly. The patient doesn't use tobacco, alcohol, or illicit drugs. Blood pressure is 114 by 66 mm of Hg and pulse is 60 per minute. Physical examination shows no abnormalities compared to a person of similar age and sex with sedentary lifestyle. Which of the following cardiac changes are most likely present in this patient? So, option A, like they have mentioned three things: left ventricular ejection fraction, with it left ventricular left ventricle cavity size, and maximum cardiac output. Option A decreased, increased, increased. Option B increased, decreased, increased. Then option C increased, decreased, unchanged. Option D unchanged, increased, increased. Option E decreased, unchanged, unchanged. Pause it and give the answer. So let us move to the correct answer. The correct answer is option D. Why? Let us see to the explanation. Since they have given the case of long distance swimmer, that is, these guys have endurance training, right? So what will happen is we will see the characteristic of those, that these guys have unchanged left ventricular ejection fraction. With that, they have left ventricular uh, cavity size is increased. Left ventricle cavity size is increased, right? And the cardiac output is also increased. So why why this is happen? Because uh, if we look to the heart of a normal person is just like that, and in these guys, the one um, which is having endurance training and the one which is uh, uh, a heavy load taker, uh, in that is of strength training, right? What is the difference between these two guys? The Let me first explain the uh, heart of the strength training. What will what will happen over there is there will be concentric left ventricular hypertrophy. What will happen is uh, in these guys there will be increased left ventricular wall thickness. This wall will be increased, right? Then in these guys there is no right ventricular changes. The right ventricle will be normal. But if you look to this case, here the wall is not increased, wall thickness is not increased. Instead, the cavity size is increased, right? With that, also the right ventricle is also increased in size, right? This is one difference. In in strength training, there is no change in diastolic filling, because here the wall thickness is increased. But in case of this, because the cavity size is increased, so there will be more filling, right? If there is more filling, then the end diastolic volume will be increased, right? And with that, what will happen is, um, in this case, the preload will be increased because of end diastolic volume. And also with that, if preload is increased, that will lead to increased stroke volume, because we know that uh, uh, we know the determinants of stroke volume like preload, afterload, uh, that are increasing, the stroke volume, right? Okay, so they are saying that uh, increase right ventricular cavity size. I talked about this. Then diastolic filling will be increased, stroke volume will be increased, but there will be uh, no change in the left ventricular ejection fraction, right? Why uh, this is important? Why? Because we know that um, ejection fraction, that is equal to stroke volume divided by end diastolic volume, right? Over here is in this case, in endurance training, both are increased. uh, I mean to say, uh, if this is increased by 2, right, stroke volume is increased by 2. With that also, the end diastolic volume is also increased. Let's say this is also increased by 2, so that will be cancelled out. So that's why there will be no change in uh, ejection fraction. In case of what? In case of endurance training, this thing is important, right? But over here, if we look to the uh, concentric hypertrophy, this is important. Here, the left ventricular ejection fraction is either unchanged or little bit increased. Why increased? Let me explain this. Uh, as we know, the ejection fraction is the same formula: stroke volume uh, divided by end-diastolic volume. Over here, as we know that the stroke volume is uh, uh, increased because of the uh, contraction, because since the heart walls are thickened, uh, that will be more uh, strengthened, right? So that will produce more stroke volume will increase, right? But the uh, diastolic end diastolic volume is remained the same. So let us say it is end diastolic volume that is remained the same. If let's say if it is increased by 2, but over here end diastolic volume is remaining the same, so that's why we can say that sometime it may increase uh, the ejection fraction, right? And one more difference is of what is uh, concentric hypertrophy and what is eccentric hypertrophy. This is important. Um, over here, uh, in strength training, there will be concentric hypertrophy, but over here, there will be eccentric hypertrophy. In case of uh, endurance training, in eccentric hypertrophy, the cavities size will be increased. They will move eccentric toward the outside, so eccentric, right? But over here, uh, there will be no increase in cavity size, but overall the thickness of the wall will be increased, because in concentric hypertrophy, uh, the muscle fibers are increased in parallel, right? But over here in eccentric hypertrophy, let's say we have this normal one, the muscle fibers will be increased in series, right? So that's why the wall is remaining the same in thickness, but the cavity size would be increased, right? So this is the difference. Okay. So let us see to the explanation. Resting cardiac output is approximately 5 liter per minute, increases to 15 liter or 25 liter per minute with exercise. Endurance athletes heart cardiac output up to 35 or 40 liter per minute. Maximum heart rate doesn't significantly increase in the highly trained athletes. Increased maximum cardiac output that is primarily due to increased stroke volume, since we know cardiac output is equal to uh, stroke volume multiplied by heart rate. Endurance training, for example, long distance swimming, increases both RBC mass and plasma volume to increase oxygen carrying capacity. Skeletal muscles increase arteriolar and capillary density, reduce systemic uh, vascular resistance. Increased blood volume and reduced uh, systemic vascular resistance contribute to increased cardiac venous return, that is preload. And eccentric hypertrophy, that is to increase left ventricular cavity size, as I mentioned, and improve diastolic filling capacity. End diastolic volume and stroke volume are both proportionally increased, so the left ventricular ejection fraction mostly unchanged. The right ventricle also undergoes similar cavity enlargement to support the increase in maximum cardiac output. So, endurance training increased maximum cardiac output via an increase in stroke volume. The left ventricle were here eccentric hypertrophy to increase left ventricular cavity size, improved diastolic filling capacity, as I mentioned, all these things, increase in end diastolic volume, increase stroke volume, and cardiac output, right? End diastolic volume and stroke volume, they are proportionally increased. So left ventricular ejection fraction is mostly unchanged. I talked about this thing, that what is the difference between eccentric hypertrophy and uh, concentric hypertrophy. One more thing which is important is uh, the more important difference is uh, one is of pressure overload, and the second one is volume overload, right? In case of concentric hypertrophy, let's say in case of chronic hypertension or aortic stenosis, if there is fluid uh, that will produce more pressure on the aortic wall, right? Or if there is the case of chronic hypertension, that will produce more pressure, right? So that will cause hypertrophy of uh, parallel type. That means if let's say this is the normal, as I mentioned, right over here, that the fibers will be increased in this manner, right? So the overall thickness of the wall will be increased, right? So sarcomeres will be increased in parallel, right? But over here, in case of volume, if let's say, uh, let me draw this. Okay, if more volume is increased, that will push the wall, okay, and that will produce more cavity, so due to which the end diastolic volume will be increased, but there will be no increase in the thickness of the wall, right? So this is important, and that happens in case of a regurgitation. The fluid will come back in aortic or mitral regurgitation or ischemic heart disease, and also associated with dilated cardiomyopathy. From the name mentioned, the heart cavity will be dilated. Okay, so that will be aided in uh, series fashion, right? If let's say if these are the normal fibers, they will be increased in this manner. Okay, as I mentioned this. So yeah, this one that will cause concentric if in parallel, uh, and if in series, that will increase in size the cavity, right? Over here the cavity size is decreased, but overall thickness is increased. Here the cavity size increased, uh, but little, no change in the wall thickness, right? Okay, we talked about this stroke volume, that is equal to end diastolic volume minus end systolic volume, right? And we talked about this ejection fraction, that is equal to stroke volume divided by end diastolic volume. Okay, so the next question is a 48-year-old man with diet controlled type 2 diabetes mellitus is being evaluated for occasional retrosternal chest pain, right? He has no history of hypertension, and his BP measurements during office visits were always within normal limits. There is no family history of cardiovascular disease. The patient undergoes exercise, treadmill, stress testing. He walks for 7 minutes on the treadmill and stops due to fatigue, but doesn't experience chest pain. His ECG doesn't show any abnormal changes. Heart rate ranges from 70 per minute at rest to 132 uh, per minute at peak, and mean blood pressure ranges from 95 mm of Hg at rest to 112 mm of Hg at peak. Which of the following parameters most was most likely decreased during peak stress compared to the resting state in this patient? Pause it and give the answer. Over here, they are asking about the parameter of resting state, right? So the correct answer over here is TPR, that is total peripheral resistance. And in that we have two types, right? Like we have systemic and we have pulmonic, right? Cardiac output in case of exercise is increased, right? And end diastolic volume left ventricular end diastolic volume is also increased because of because the there will be peripheral vasoconstriction, so there will be more blood flow uh, that will come uh, from the periphery to the heart, right? So the end diastolic volume will be increased. With that, end diastolic pressure will also be increased, right? So both are increased. Pulmonic uh, systolic pressure, that is pulmonary artery systolic pressure, that is also increased, right? And also with that, systemic systolic blood pressure, that is also increased because of uh, preload, right? Okay, so the correct option is uh, um, total systemic vascular resistance, that is decreased. This is the one uh, uh, one thing, one factor which is decreased during exercise, because we have to increase blood flow, right? For that, there should be low resistance, right? So that blood can easily reach to the skeletal muscle, right? For in case of exercise. Okay, so I had mentioned this, during exercise there will be increased heart rate, right? To increase stroke volume, uh, right? That will lead to increase. One thing you should remember this: at a higher level of exercise, heart rate is predominantly responsible for most of the increase in cardiac output, right? Like we have for cardiac output, we have two things. Cardiac output is determined by two things, like stroke volume uh, multiplied by heart rate, right? So in higher exercise, predominant uh, determinant is heart rate, right? And uh, not stroke volume, right? Okay, I talked about this, that uh, left ventricular end diastolic volume and left ventricular end diastolic pressure both increases due to increase in venous return. Why not option C, increased during exercise? Systolic blood pressure, that is also increased, right? uh, I mentioned this. Why TPR is decreased? Because of adenosine, right? Adenosine is produced from ATP breakdown. With that also potassium carbon dioxide and lactate, that will also cause vasodilation, right? Okay, so this is exercise physiology. What will happen is increase muscle okay, muscular activity, right? What will happen is there will be uh, venous constriction and increase preload. With that, cardiac output will be increased. um, with that, stimulation of muscle chemo and mechanoreceptors, that will increase sympathetic outflow, that will increase cardiac contractility in heart rate. With that, resting muscle and splenic vasoconstriction, because there is no need of uh, work in these areas, right? And with that, local metabolite production, uh, what they will cause, they will dilate arterioles, okay, within active muscles, right? That means the TPR will be reduced, the total peripheral resistance, right? So ultimately, that will increase the blood supply to active muscles. Okay, let us have a quick uh, flow through these. Exercise, uh, sympathetic activation and withdrawal of vagal tone, increase heart rate, stroke volume, and overall cardiac output. At higher level of exercise, I talked about this. Sympathetic discharge causes increase in the systolic BP, right? We talked about this. Overall decrease in systemic vascular resistance. This is the answer. Okay, we talked about these things. Okay, uh, left ventricular end diastolic volume and pressure both rise because of increased venous return, right? The mechanism is uh, peripheral vasoconstriction and the pumping actions of actively contracting muscle, right? Um in option C, pulmonic pressure rises during exercise. The reason behind it, there is the rise in pulmonary pressure is much smaller than increase in the blood flow across the pulmonary circulation due to fall in pulmonary vascular resistance. We know about this, right? That both the resistances will be decreased, and this is the answer for this question. So, exercising muscles, 85% of the total cardiac output during periods of strenuous activity. Sympathetic discharge during exercise, what will happen? That will increase cardiac output and splenic vasoconstriction because we do not need uh, any work over there. So there is only a modest increase in the mean blood pressure. Is vasodilation within active skeletal muscle significantly uh, decreases the total systemic vascular resistance. Right. Okay. The next question. A group of forensic pathologists are analyzing tissue samples of adolescents aged 13 to 18 to study the aging process. Autopsy of 14-year-old boy who died in a motor vehicle accident shows several minimally raised yellow spots on the inner surface of the abdominal aorta. The rest of the cardiovascular findings during the autopsy are unremarkable. He had no known medical problems. There was no family history of cardiovascular disease or sudden cardiac death. Which of the following is most likely to be the predominant cell type in these lesions under light microscopy? Right? So the correct option for this question is macrophages. Right? Because these are associated with fatty streaks. Because these will form foam cells. Right? The other cells are not that much predominant. Right? Okay. One thing uh, over here is age is important, right? Because the uh, process of atherosclerosis is usually started uh, during the second decade of life, right? So age is important of patient. Any question when you go through that, note the age of the patient, right? Okay. So yellow spots on the inner surface of the abdominal aorta, right? As I mentioned, macrophages forming foam cells in the fatty streaks. Okay, uh, they have mentioned the phenomena of formation of atheroma, right? What will happen? First, there will be endothelial dysfunction, right? LDL will be uh, entered to the basal wall, right? Uh, that will be converted into oxidized LDL. Uh, that will go to the macrophages, and with that T cell will produce cytokines that will also activate macrophages, right? So what will happen is whenever the monocyte come to the uh, come inside the vessel wall, they will and they get mature, they will be converted into macrophages, and then they will take lipid, right? And they will form foam cell, right? And with that um, there will be platelet adhesion, and these things together will produce uh, platelet derived growth factor um, that will promote the uh, formation of these uh, cholesterol, and with it there will be the accumulation of extracellular lipids and necrotic debris, and also with that there will be the smooth muscle cell migration, and also with that there will be collagen synthesis. Okay, so fairy streaks, right? uh, this is the earliest sign, earliest thing which happen in the formation of atheroma, right? So earliest lesions in the progression to atherosclerosis and seen is early is the second decade of life. As I mentioned, age is important. Atherosclerosis begins in childhood. This is also important thing. Note this point. What will happen in atherosclerosis is the focal intimal thickening and lipid accumulation. This is the definition of atherosclerosis. Note this point, right? What is the mechanism through which this atherosclerosis process is going? What will happen is we go through that, but let me explain it again. Endothelial injury and dysfunction will cause increased vascular permeability and enhance leukocyte adhesion. Uh, what will happen due to that? Lipoprotein um, accumulation will occur within the vessel wall. We talked about this thing, right? Then what will happen? Monocyte adhesion to the endothelium, followed by migration, then transformation into lipid-laden macrophages. This is important definition. Form cells are formed. What are form cells? These are lipid-laden macrophages. Note this point. Lipid-laden macrophages are form cells. What will happen next? Release of growth factors by adherent platelets, activated macrophages, and endothelial cells. Then recruitment of T cells and smooth muscle cell proliferation lead to extracellular matrix production. As I mentioned, there will be collagen synthesis. Okay. Then, with advancing age, the chronic inflammatory process initiated by endothelial injury transition from fatty streaks within the intima, composed mainly of lipid laden form cells, into atherosclerotic plaques such as fibrous cape, atheromas, and fibrous plaques. This is with advancing age. This is important. With advancing age, fatty streaks will be converted into fibrous cape, atheromas, and fibrous plaque. Right? Why not option A, B, D, and E? These cells are not the predominant cell, as I mentioned about this. Fatty streaks are the earliest lesions of atherosclerosis, seen as early as the second decade of life. Collection of lipid-laden macrophages, do not forget about this thing, in the intima. Eventually progress to atherosclerotic plaques with advancing age. This is important, right? Okay, thank you.